Good morning, everyone. I'm Stephanie. I'm one of the second-year neurology residents, and today I'll be presenting a case on a 62-year-old female with a past medical history of hypertension, tobacco use, spontaneous coronary artery dissection a few years ago, as well as multiple aneurysmal dilations. Chief concern is acute left eye swelling. She presented to an outside hospital, and her story was that she said she was sitting on her couch, looking at her iPad, and she noticed that she was having trouble keeping her left eye open, and she was starting to have some swelling and some pain. So on physical exam and also radiologically, we saw that she had left periorbital edema with some evidence of some skin breakdown right over the upper lid. She otherwise had full extraocular movements, no afferent pupillary defect, visual fields and acuity were intact when we were able to get her eyelid raised. Dilated fundus exam showed that her optic nerves didn't have any edema or pallor suggestive of papilledema. And then otherwise, her neurologic exam was unremarkable. In the outside hospital, she got a CT head without contrast, and it redemonstrated the significant amount of periorbital edema that she had over her left eye. But as you can see, she also seemed to have some hyperdensity within the subarachnoid space, suggestive of a right subarachnoid hemorrhage that appeared to be traumatic, but in questioning her, she had never had any type of trauma to her eye or to her head at all. And so when she was transferred over for management of her subarachnoid hemorrhage, she got a CTA here, and it showed a very small 4-millimeter conical left ICA terminus aneurysm, as well as a 2-millimeter right ICA supraclinoid aneurysm. And so in thinking about her case, she was someone who presented with a subarachnoid that appeared to be non-traumatic. She had several intracranial aneurysms, as well as extracranial aneurysms. She had aneurysmal dilation of her ascending thoracic, descending aorta. She had bilateral subclavian artery aneurysms and also had a right brachiocephalic artery aneurysm. And then in the absence of trauma, although we suspect she probably syncopized and hit her head and didn't remember, the amount of periorbital edema that she had and bruising seemed excessive for her story. And so trying to put her together, we thought maybe she might have a connective tissue disorder. We talked to rheumatology to see if it might be an inflammatory or autoimmune connective tissue disorder, but they were actually more suspicious of a genetic connective tissue disorder called Loeys-Dietz syndrome. It's an autosomal dominant genetic connective tissue disorder. The majority of people actually have sporadic mutations, about 75% of patients, and 25% of patients have heritable mutations. In terms of clinical manifestations, 4 major organ systems are affected. Cardiovascular system is the most affected. Aneurysms and dissections are common, and it most often affects the ascending aorta. You can also see skeletal features like cervical spine instability, osteoporosis. Craniofacial features are also common, although many patients don't have any of these features. These include widespread eyes, bifid uvula, cleft palate. And lastly, easy bruising is a very common presentation for patients, as well as translucent skin and blue sclera. And our patient definitely had a significant easy bruising and a pretty exaggerated response to injury. Because of the heterogeneity of phenotypes and its range from very mild symptoms to very severe symptoms, there's no clinical diagnosis. It's really all based off of genetic testing. The causative mutations are all found within the TGF-beta signaling pathway. It either affects the TGF-beta signaling molecule, either 2 or 3, or it affects the receptor, or it affects an intracellular effector molecule called SMAD2 that once it attaches to the co-SMAD, enters the nucleus and it affects transcription that later on leads to increased TGF-beta signaling and loss and disruption of elastic fibers, which end up compromising the stretch of the tissue. And then you see pathologically that there's collagen accumulating within the media. In terms of management for Loeys-Dietz syndrome, it's important to recognize this disorder because the complications can be pretty devastating. Once we suspect this disorder, patients end up getting echocardiograms annually, and vessel imaging annually to try to categorize or quantify the burden of aneurysms or vessel injury. They get spine and neck x-rays to look at cervical instability and DEXA scans for osteoporosis. Again, it's important to recognize if someone has Loeys-Dietz syndrome, because even though there's no curative treatment, there's preventative treatment in the form of losartan. And interestingly, what losartan does, and I guess I didn't have a signaling pathway for it, but if you can imagine the cell membrane with an additional receptor called AT1R, angiotensin 2 binds to this AT1R receptor, and it actually enhances SMAD signaling. But when you give a patient losartan that binds or antagonizes angiotensin 2, then you have a reduction of the SMAD signaling. So it actually leads to decreased SMAD activity and its effect on transcription. So it actually can prevent a lot of the devastating complications within this disease. And otherwise, for treatment, it really is just losartan and other surgical repair of vascular anomalies. And I just wanted to incorporate a diagram of related disorders, because oftentimes when you think of heritable connective tissue disorders, we think of Marfan's or Ehlers-Danlos. But it's important to recognize that even in someone who's in their 60s, they can still have a genetic cause for a connective tissue disorder. And that is it. Thank you.
Thank you, Stephanie. That was wonderful. And it's, the story of Hal Dietz and this syndrome, it was probably described, what, 15 years ago? And the treatment and the treatment with ARBs within 2 years, by working out the pathophysiology and the molecular genetics, he proposed that ARBs would be actually a preventive treatment, and it turned out to be the case. It's quite an amazing story. I want to thank Andrew, who has arranged for our grand round speaker, and I guess I have to hit stop share, and we'll turn it over to Andrew and our guest speaker. Take it away, Andrew.
Thank you. Good morning, everyone. Welcome to our residency applicants. I'm excited. I'll meet you all throughout the day today, so I'm looking forward to that. A little context for you. Our Diversity and Inclusion Committee sponsors a Diversity and Inclusion speaker series through Grand Rounds. Today will be the first one of our academic year, and our speaker is Dr. Gabby Byrd. She's an assistant professor of intergroup health communication and community resilience in the Brian Lamb School of Communication at Purdue University. Dr. Byrd's research focuses on the relationship between communication and disability, stereotypes, and relational and identity processes. She's specifically interested in exploring the ways in which positive and effective communication can reduce intergroup anxiety, group level stereotyping, and improve outcomes for marginalized people in their personal relationships, workplaces, and healthcare contexts. She's published papers on these topics and presented at regional, national, and international conferences. And we asked her to speak today because I think because the Diversity and Inclusion Committee felt that our communication was a big factor in both our relationships within the department and between our patient care relationships. So she will be speaking to that today, and I'll turn it over to Dr. Byrd.
Thank you so much. Let me get this up and going. Are you able to see the PowerPoint here?
Yep, looks great.
Okay, perfect. Thank you so much for that wonderful introduction. I'm so excited to be here with you all today. And I'm going to be presenting on what I'm calling reducing intergroup anxiety, communication that cultivates inclusive environments for all. And just to introduce myself a little bit further, I'm a communication researcher and teacher, first and foremost. Intergroup communication and health communication are really where my heart lays, but I really am interested in these intergroup interactions, which we'll talk about today. And I've highlighted intergroup anxiety and intergroup contact and interactions because that's what we're going to focus our attention on today. So a little bit of an agenda. We're going to start by talking about intergroup communication and intergroup anxiety, since I'm not exactly familiar with how much you all know about these concepts in this area of study. Then I'm going to talk briefly about a few exemplar studies that really highlight the need to reduce intergroup anxiety in this healthcare context. And then I want to give you some ways to think about how you can reduce intergroup anxiety. I want us to really think about communication. How can we use our communication to reduce intergroup anxiety? So, healthcare organizations. Health organizations, as you all know firsthand, are wildly increasing in cultural diversity, which we all are so excited about, right? And so healthcare workers, it's prime time to start considering the roles that your identities and the roles of your patients in the care process. Whether we like it or not, our own identities, as objective as we may want to be, our identities play a role in our communication and our interactions. And when you're interacting with your colleagues, your identities are also playing a role. And so what's happening here is that all of these interactions are becoming intergroup communication. And intergroup communication, that's these interactions and communication between people who belong to different cultural groups. And originally, intergroup communication was really thought of, when I say cultural groups, it was thought of as our nationality or as our ethnicity. But that was over 50 years ago, and we've really started to think more broadly. So we don't just think of it as race, ethnicity, or nationality, but we also think about things like our socioeconomic status, our religion, our age, our disability status, sexual orientation, gender, education, language, and even in the healthcare context, when you're interacting with your colleagues and coworkers, your differing medical specialties can make an interaction, intergroup communication. So intergroup communication can happen in your workplace in 100 different ways. And I'm not wildly familiar with Duke or North Carolina, but just some preliminary research shows that this is really a diversified and increasingly diversifying area. And so your patients are becoming more and more diverse. And so not only do you need to be prepared to interact with your colleagues, but also with your patients who are more and more diverse, which, depending on your background, is going to qualify these as intergroup interactions. And so throughout today's presentation, one of the terms that I'm going to be using is in-group and out-group communication. You may be an in-group member or an out-group member. And so in-group members are, or an in-group is that group that you belong to or identify with. So all of you are either studying to become or are already doctors. So that is an in-group membership that you belong to. And so people that are not doctors, that is the out-group. Those are out-group members that people do not belong to or identify with. And out-group identification, this serves as a basis for categorizing other people into in-groups and out-groups. And this categorization process can elicit a host of in-group, out-group biases that generate intergroup anxiety, which is what we're going to talk about today. Just going to make sure that we didn't have anything in the chat, but not for me, so perfect. So when we're taking part in this intergroup interaction or intergroup communication in healthcare, it can influence our patient care and our teamwork. So I've just given a few examples here of the ways that it can influence patient care. So research has shown us that for patient care, when compared to when patient care is in-group, intergroup patient care has increased anxiety for both patients and providers, increased perceptions of miscommunication by patients, And even when patient care is considered intergroup, patients show a decreased adherence to treatment. So that's really huge. Patients are less likely to adhere to the treatment that you are prescribing to them if they categorize you as an outgroup member and if they experience intergroup anxiety. So that can be really devastating to your patients. And for teamwork, when you are working with members who belong to an outgroup, again, that increased anxiety is happening. There's issues with decision-making and trust, and you may underperform teams who belong to an in-group together. And we could spend days, weeks, semesters talking about each of these individual topics. But as I've highlighted here today, we're just going to talk about intergroup anxiety. So what is intergroup anxiety? I'm sure you've all heard of social anxiety. You're very familiar with these topics, generalized anxiety. But intergroup anxiety has been found to be a unique concept, a unique experience. So intergroup anxiety is an anxiety that stems from contact with outgroup members. And this is often experienced before and during interaction with people from different cultures. And again, this can be interaction with people from all different cultures, right? We're thinking not just about national culture, we're thinking about different education status, socioeconomic status, sexual orientation, et cetera. And this can also occur within cultures. So if you're taking part in interactions between members of stigmatized and non-stigmatized groups, if you belong to the LGBTQ+ community and you are engaging in communication with a heterosexual individual, you may experience intergroup anxiety. And then also between individuals belonging to different hierarchical groups. So nurses and doctors, think about the different hierarchical groups that belong to your organization. And I want us to think about how intergroup anxiety is experienced. Intergroup anxiety has been found to be experienced affectively, behaviorally, and cognitively. So we'll start by talking about intergroup anxiety as an affective experience. Affectively, this is what we think of when we think of anxiety, right? It's a negative and aversive experience. So I'm apprehensive, I'm distressed, I'm uneasy, I'm self-conscious about what I'm saying. This is that butterflies in your stomach, I'm anxious experience. But we also know that intergroup anxiety is experienced cognitively. So concerns related to cognition here, that means that we may worry about the negative psychological consequences for us when we engage in intergroup communication. So we may be worried about being embarrassed, misunderstood, we're scared, confused, irritated, frustrated. We're worried that we'll be viewed as incompetent. We may also be worried or concerned about the negative behavioral consequences for ourselves. If we belong to a stigmatized group, we might be worried about being discriminated against, physically harmed, deceived, exploited, things like that. The cognitive component also deals with worrying about being negatively evaluated. So we may be worried about rejection. Then we have the physiological component. So intergroup researchers have started working with medical doctors to look at the physiological component. And this is where I normally say, I'm not a medical doctor, right? I'm a PhD. So you all obviously understand this physiological component a lot better than I do. But in intergroup context, when experiencing intergroup anxiety, people experience these negative outcomes of these elevated responses, increased blood pressure, cortisol levels. So these are really negative outcomes. So it's not just an experience that we're feeling affectively or emotionally, but it's also a physical experience. And we've started to understand, and actually now have a very sophisticated understanding of the antecedents and consequences of intergroup anxiety. So first, personality traits and other relatively enduring personal characteristics can predispose us to experience intergroup anxiety. So personality traits can influence how intergroup interactions are framed, how we think about what's going to happen in an intergroup interaction, which causes us to experience intergroup anxiety. So the traits that are most likely to predispose us to experience intergroup anxiety are those that lead us to be more prejudiced, ethnocentric, mistrustful, cause us to not really like ambiguity or uncertainty. If we're lacking in self-confidence or in empathy, or lower in cognitive complexity, then individuals with those related traits are more fearful of interacting with members of groups that are different than them and are more likely to experience intergroup anxiety. So these individuals may not feel competent to interact successfully with outgroup members. They may expect the worst from members of their group, of other groups, anticipate being disliked or rejected, and expect intergroup interactions to be difficult and distressing. Another type of personality trait that influence intergroup anxiety is social group membership. So if we really strongly identify with one of those social group memberships that we talked about, like national, ethnic, religious, or gender identity groups, then we expect to experience intergroup anxiety at a higher level. The high value that we place on our own group membership, it oftentimes leads us to be apprehensive about the threats that that might pose to our identification with our own group. Then, closely related to that first point about personality traits, the second antecedent to experiencing intergroup anxiety is attitudes and related cognitions. So negative attitudes and perceptions of outgroups are important antecedents of intergroup anxiety. The relevant negative attitudes and perceptions form the basis for negative expectations concerning intergroup interactions. So you're probably seeing a pattern here. Anything that causes us to expect something negative to happen when we interact with people who are different from us is going to cause us to be experience a higher likelihood of experiencing intergroup anxiety. So prior prejudice toward outgroup members, negative stereotypes should promote higher intergroup anxiety. In the last 6 or 7 years, we've really seen this in the political arena, right? People who are really strongly identified with their political party and have negative attitudes and stereotypes toward the opposite political party. Then when they interact with the opposite political party, they experience this really high intergroup anxiety. And a lot of this is due to concern that their negative attitudes will be obvious to the group that they're interacting with, and they might be treated negatively as a reaction to that. Third is personal experience. So if you have very little personal experience with people who are different from you, and you lack the experience and knowledge of outgroup members, then that leads to a lot of anxiety. So the limited understanding of outgroup members' beliefs, values, norms, and social practices leads to a lot of uncertainty and anxiety. And it hinders us from being able to empathize and understand other people's ways of doing things. And the last is situational factors. So the level of intergroup anxiety that we might experience might be just due to the situation that we're in. So if a situation is characterized by competition, unequal ratios of in-group to out-group members, so if you're the only person in your in-group with a lot of people from a different out-group, then you may experience more intergroup anxiety. Also, status difference. That's oftentimes why we see patients experience intergroup anxiety in interactions with healthcare providers, because they experience status difference. Situational factors like unfriendly behavior, arguments, misunderstanding, rudeness, lack of respect, and discrimination or aggression also lead to heightened intergroup anxiety. So now that we understand some of these causes of intergroup anxiety, what are the consequences? So first, the affective responses or the affective consequences are negative emotions. When I experience heightened intergroup anxiety, I'm left with negative emotions. Seems rather obvious or simple, right? I might feel fear, anger, threatened, dread, embarrassment, etc. But what emotion I experience depends on what type of cognition or situational factor caused my intergroup anxiety. So for instance, if I expect physical harm, I might then experience fear as a consequence. If I experience intergroup anxiety as a response to unjust treatment due to my social identity group, then maybe anger will be activated. For your patients, if they experience intergroup anxiety because they're expecting poor medical news, then maybe they'll activate fear or dread. So whatever the affective response is, that's due to the antecedent that caused the intergroup anxiety. Then we also experience consequences on our verbal and nonverbal communication. So as a result of experiencing intergroup anxiety, people experience speech difficulties. They may raise their volume really high. They may be restless, tapping their feet, avert their gaze, just general awkwardness that manifests in a lot of different nonverbal behavior. Also, things like avoiding group members, terminating intergroup interactions, being distracted, not listening, being unwilling to help. So you can think about all the ways that these nonverbal behaviors would be very dangerous and damaging in a healthcare context. And we'll talk about that when we go through some exemplar studies. And then cognitive responses. So intergroup anxiety is oftentimes called a direct source of bias. So when you experience intergroup anxiety as a result of intergroup contact, it oftentimes leads to negative attitudes toward that group and increased stereotyping. So it's really important that we reduce our anxiety so that we can have more positive attitudes toward that group as a whole. So this is that model as a whole that explains the antecedents and consequences of intergroup anxiety. And that really depicts the critical importance of reducing intergroup anxiety. And to really bring that to life, I want us to talk about a couple studies in the healthcare context that show why it's important to reduce our anxiety. And then we'll move on to talking about some communication strategies. So the first study is looking at intergroup contact and team functioning among nursing students. And this is looking at the mediating role of intergroup anxiety. So this is really looking at the importance of reducing intergroup anxiety in order to have effective teamwork. So this first study explored how Italian nursing students experienced intergroup anxiety when interacting with their migrant colleagues. So here we can see that frequent and positive communication between native and non-native healthcare professionals was able to decrease the amount of intergroup anxiety that the native healthcare workers experienced. The ability to decrease intergroup anxiety between these groups is essential, since intergroup anxiety in this study was shown to increase prejudice and decrease teamwork functioning in this healthcare setting. The improvement of team effectivity is one of the main concerns of healthcare organizations. And this study demonstrates that frequent and positive face-to-face communication between outgroup colleagues can reduce intergroup anxiety and increase team functioning. And we'll talk in a minute about what that face-to-face positive and frequent contact can look like. The next thing we'll look at is intergroup anxiety in pain care. And I'm just going to move a little bit quickly so we have some time for questions. But this second study explored intergroup anxiety in pain care, specifically between white doctors and their Black patients. This was done since a majority of Black patients are treated by white providers. And here, while a majority of Black patients, white doctors' higher intergroup anxiety predicted lower levels of comfort treating Black patients. And this was associated with higher likelihood of prescribing and recommending opioids and higher pain specialist referrals for Black patients. So here we can see how white providers experiencing high levels of intergroup anxiety and the resulting situational discomfort in treating Black patients has negative implications for decision-making processes and treatment plans recommended to Black patients. And the third study that we're going to look at briefly is meta-stereotypes impairing doctor-patient relationships or doctor-patient relations, the roles of intergroup anxiety and patient trust. So this study examined whether patients' negative meta-stereotypes undermined their perception of doctor-patient relations by raising their intergroup anxiety and decreasing patients' trust with doctors. So 140 outpatients from a Chinese hospital participated in this study. And results revealed that when patients activated negative meta-stereotypes, so essentially when patients believed doctors had a negative impression of them as a patient or as a person, they expressed higher intergroup anxiety, lower levels of trust with their physician, and poor doctor-patient relations. So this shows that activating negative meta-stereotypes can increase negative appraisals in the doctor-patient relationship and damage patient trust. So a patient may be less likely to seek medical advice in the future as a result of intergroup anxiety. Altogether, these three exemplar studies show the critical need to reduce intergroup anxiety in order to increase team effectivity, increase decision-making in treating patients, and improve doctor-patient relationships. So, how can we reduce our intergroup anxiety to avoid these negative outcomes? And this is really what my research focuses on. I'm interested in what forms of positive communication can reduce intergroup anxiety and improve outcomes. So let's start by thinking about ways to reduce our intergroup anxiety in interactions with coworkers. So with coworkers, as we saw, frequent and positive communication is really important. So frequent and positive communication is kind of vague, right? We should frequently interact with our coworkers. But what does positively communicating with them mean? We may want to socially support our coworkers, and this may include tangible support, so helping with work tasks, emotional support, showing interest in others, listening, informational support, sharing suggestions and information, and self-disclosure. Self-disclosure is shown to be one of the strongest predictors of building relationships and of reducing intergroup anxiety. So if you can find ways to self-disclose about yourself in ways that are appropriate, of course, to a workplace context, you will be able to reduce intergroup anxiety. And then build relational solidarity. So if you are able to engage in frequent and positive communication, socially support your colleagues, and engage in self-disclosure, you will build relational solidarity. You will have pleasant and close relationships with your colleagues that will hopefully reduce intergroup anxiety. So I hope you all have some ideas as well about communication strategies that you can use to reduce intergroup anxiety. Then with your patients, I think one of the most important ways to reduce intergroup anxiety when you are interacting with your patients, but also to think of ways that you can help your patients reduce their intergroup anxiety when interacting with you. So can you identify when patients are experiencing intergroup anxiety? I think you need to think of ways to start engaging in mindfulness and become aware of intergroup anxiety. So can you identify when you or your patients are exhibiting those behavioral manifestations or behavioral consequences of intergroup anxiety? Then with patients, if you can demonstrate that you are engaging in perspective taking, if you can communicate to patients that you can imagine how you would feel if you were in their place, of course, in appropriate ways. If you can demonstrate empathy and engage in supportive communication, and find ways to appropriately combine tangible, emotional, and informational support to patients. This allows for a positive combination of intergroup communication that will reduce intergroup anxiety. So what should you do? What can you do? Be mindful of when you are experiencing intergroup anxiety, and when you are, use strategies to manage and/or reduce intergroup anxiety. There's 3 general strategies that we can use to reduce our sense of uncertainty and anxiety. And the first is passive, but the real first is to understand that we all experience intergroup anxiety. But the first, passive strategies, and these are quiet observation of the other person that may be the person that you're experiencing intergroup anxiety interacting with. So we may just observe and see how they communicate, see what their norms are, what their social practices are, and use that to inform and act on in the future. Then there are active strategies. And this includes obtaining information about this other person by asking others who are familiar with this person and with their culture. So maybe you can't actually ask this person directly, but you have someone, a friend or a colleague or a family member who also belongs to this culture, and you're able to gather information in that way. Both the passive and active strategies are things that we can do before we interact with our interaction partner to minimize our sense of uncertainty and anxiety. I think that we all have walked away from communication interactions and been like, that did not go well. How do I improve that in the future? And so these are 3 ways to kind of course correct and find solutions for our intergroup anxiety. And the interactive strategy is when you're actually interacting with this person. And these are things that you can do by directly intervening and conversing with the other person in an attempt to gather the needed information to reduce your anxiety and uncertainty. And it's important that you mobilize all three of these different strategies to minimize your sense of uncertainty and anxiety in intergroup communication moments. And it might be important that you help your colleagues and patients mobilize these strategies as well to reduce their intergroup anxiety. So, next steps. Continue reading and learning about intergroup anxiety. This Stefan 2014 piece is a really good place to start. Take small steps in your sphere of influence to help others learn about the importance of reducing intergroup anxiety, and begin being mindful of your experiencing intergroup anxiety and how you can reduce it. Thank you so much for listening, and I look forward to answering any questions that you might have.
Thank you so much. That was really, really useful. It's a topic that I think we've all experienced and yet don't always discuss or have language to describe. So I think it's really helpful to hear this framework and understand it, because as you said, that just being mindful of the experience is an important way to start. Understand what you're feeling in that situation, and that others feel it too. I'm going to get the ball rolling with the question. You're talking about in-group and out-group, and I know this is experienced on sort of both sides and of the power dynamic. Can you talk a little bit about how this can impact even those who have maybe more power, more social status? It's not always from the more marginalized group that this is coming into play.
Absolutely. Absolutely. So most of my research does focus on marginalized groups, right? But both groups are being affected by this in-group, out-group dynamic. And so we often talk about this in the academic setting as well, right? Tenure track faculty versus non-tenure track faculty. Tenure track faculty have the most power, but that doesn't mean they're not affected by these in-group, out-group dynamics. Same with doctors. It happens in all these ways. And so the person that has the power, people experience intergroup anxiety when interacting with people in power, because of the status differences, right? That's an antecedent of intergroup anxiety. And so if the status difference is creating an intergroup anxiety, that negatively impacts both people in the interaction, including the person in the position of power. So we have to figure out how to move forward. And sometimes that's just recognizing that you're in the position of power and figuring out how both people can move forward and reduce anxiety. But I think that that's absolutely true. It's not just important for marginalized communities to understand. And also when we are interacting with people in positions of power, sometimes we come with negative mindsets as well. So.
And I would think that it can even impact things like mentorship. If you're going to experience intergroup anxiety, maybe you avoid that interaction, which would have benefited the person with less power, because maybe you don't offer the same mentorship or something just to avoid that anxiety feeling with that out group, and it can make matters worse because then you're just sort of avoiding it.
Oh, absolutely. And if we were to look at all of the communicative consequences of intergroup anxiety, one of the largest is willingness to communicate, right? So if we experience intergroup anxiety, we have no willingness to communicate. And so if we think about this from a learning standpoint, if you have this intergroup anxiety with your mentor or the person that's teaching you, and then you become unwilling to communicate, you are losing out on so many learning opportunities. So yeah, that is such a bummer for you, because that might be really beneficial to your career and to you as a person.
Thanks. Let me, anyone?
Yeah, I'll take a
more?
shot. Well, so I think that these intergroup anxieties are not always the result of just differences in power. I think there are male-female differences, race differences when, you know, a white person is talking to a black, independent of the power relationship of that. And I think that's something that it's important to realize, you know, within yourself, because you don't want to avoid conversations or things just on the basis of something like that. And I don't think we should ignore that. I think it's a big issue. And then the other thing is with patients, I think the most important thing to break down barriers is a smile. And we've spent the last 3 years with our faces covered while we have patient interactions.
Absolutely. And your first point is so important, right? There's so many different things that impact our intergroup communication. It can be age, race, gender, all of these things play an important role. And then to your second point, I totally agree, right? I don't treat patients, but I am a teacher, and having to teach to my students with a mask on and them never seeing my nonverbals, them never seeing my face, it's really challenging to develop that rapport for them to see. And when you're dealing with a really anxious patient and you can't relate to them in that way, I can't imagine how challenging that would be.
So there are other ways.
Mhm.
Let me just reach down here. We have the prime example in our department of Rick Bedlack, who disarms his patients by wearing fancy but wacky suits when he goes to clinic. And what I started doing, if anyone can see it, this is my sock.
Oh,
So,
nice.
although they can't see my face, they can see my sock. And it's amazing how many patients point it out. And I think that's another thing, at least to cut some of the tension in the room.
And I think that's such a great example because, you know, doctors are under increasing pressure to have such a short amount of time with patients. So what can you do to reduce a patient's anxiety with less and less time? So if it can be goofy socks or a fun suit or a pin, or what can you do to help patients with less and less time? I think that's really important.
So
Right. Go ahead, Andrew.
Dr. Sanders had a
Wait.
question. He texted me, so I'm going to read his question because
Oh.
it came straight to me. But this is from Dr. Sanders. He wants to ask you about the importance of the term we used. We use a first name or an honorific, a title, and how that can adjust the anxiety in the interaction.
Both between patients and doctors, and let's say residents and faculty, or things like that.
That's a great question. And, you know, that is not something that I have empirical evidence to support, but it's something that I think about a lot with my students as well. And I think it does play a role, right? If you have a patient call you doctor, or even a resident or a nurse or whoever, you are creating a power distance between yourself and that other person. So I think that it's a true serious decision that you have to make. And I think you also can use that strategically. So if you go by doctor and in a moment of anxiety for a patient, you say, hey, call me Gabby. That can be a really true bonding moment between you and a patient.
So what's the evidence like around? My understanding is that, like, if the boss is on a first name basis with a lot of the employees, you're much more likely to tell that boss things that are going on that maybe they should hear about. But on the other hand, there is sometimes the power role of being a boss does matter. And if everyone's calling you by your first name, you might have forfeited that. So what's your take on that?
I think that is that's challenging. That all has to deal with power distance as well. And I think that you're making a decision to have a more democratic system. And you may learn more because your employees may be more comfortable with you, but there is evidence to say that that can get a little bit messy as well.
Yeah. No free lunch,
Yeah.
but there is free breakfast if you were here in Durham today. All right. Well, thank you very much for the talk. It was really interesting. Thanks, Andrew, for setting it up, and everyone have a great day.
Thank you for having me. I really
Yeah.
enjoyed our discussion.
All right, thank you for coming.
Thank you.